Finals SAQ50, CPET and other risk assessment tools. A. List the main measures of fitness that are obtained by a cardiopulmonary exercise test, CPET. This includes anaerobic threshold, peak oxygen delivery, VO2 peak, and ventilatory equivalents for carbon dioxide. AT is the oxygen uptake occurring at the point when the oxygen requirements of exercising muscle exceeds supply and energy provision begins to be met by anaerobic metabolic pathways. AT of less than 11 mL per kg per minute places patients in the high-risk category, more than 18%, for CVS side effects following major general surgery. VO2 peak in mL per kg per minute is the highest oxygen uptake achieved on a rapid incremental test at the end exercise. Ventilatory equivalent for carbon dioxide are indicators of ventilatory efficiency, representing the ratio of minute ventilation to CO2 output at any point of time. B. What abnormalities seen at the time of testing in CPET may suggest cardiorespiratory disease? For cardiac, this includes rapid increase in heart rate, especially at low levels of work, reduced heart rate reserve, reduced peak oxygen pulse, which reflects stroke volume, pathologically altered ECG with exercise, and hypotension with exercise. Respiratory signs includes increased ventilatory equivalent for CO2 or oxygen, spirometry abnormalities such as significant reduction in FVC, FEV1 or both, and significant reduction in oxygen saturations at peak exercise. C. When might CPET using a bike be impractical? And how else can patients' functional capacity be assessed? Tips. There is a list of situations where CPET is contraindicated, such as severe aortic stenosis, recent MI and respiratory failure. However, this question is asking about situations where it may be impractical, such as history of amputation that has compromised ability to use a bicycle, severe peripheral vascular disease, severe arthritis, balance or coordination problems, inability to tolerate face mask or mouthpiece due to claustrophobia, and lack of motivation. Other methods of assessing patients' functional capacity includes questionnaire-based approaches such as Duke Activity Status Index, 6-minute walk test, incremental shuttle walk test, and CPET using a hand crank. However, results are not comparable to results from bike CPET due to different muscle groups and sizes of muscles involved. D. What scoring systems can help predict perioperative risk before major non-cardiac surgery? This includes generic scoring systems such as ASA, POSSUM, SORT, ACS, NSQIP, and CACI. Scores for cardiac risk includes the Revised Cardiac Risk Index, RCRI. Scores of respiratory comorbidity includes Arozullah Respiratory Failure Index, Gupta calculators for post-op respiratory failure and pneumonia, and ARISCAT Risk Index. Scores for specific operations or operation types includes Nottingham Hip Fracture Score, V-POSSUM, and Charlson Risk Calculator for survival after elective AAA repair. Chairman's report, 24.3% pass rate. Question was not well answered, which is surprising given widespread use of CPET. Inclusion of perioperative medicine in curriculum hopefully leads to more exposure to this and other pre-operative testing methods, and to a greater understanding of risk assessment in general. Additional information. Perioperative risk can be estimated using functional assessment, risk assessment tools, and biomarkers. This table shows common events and risk in anesthesia. Data sourced from the Royal College of Anaesthetists. Functional assessment. Objective functional capacity assessments are required to support preoperative risk stratifications. Functional assessment tools suffer from a paucity of evidence and lack of unified definition regarding the outcomes that are of most importance to patients. Subjective assessments have been shown to be less accurate at identifying those with poor cardiopulmonary fitness and in predicting post-op complications. Test of functional capacity. 6-minute walk test. The former conduct has been described by the American Thoracic Society. Patient walks as many laps as possible in 6 minutes on a flat indoor 30-meter course. It is simple and cheap. There is weak correlation between 6-minute walk test and CPET, and moderate correlation between 6-minute walk test and DASI scores. Exercise ECG and pharmacological stress testing. This is for detection of MI, identification of those who may benefit from pre-op PCI or CABG, and as an indication for functional capacity. Those with pre-existing ECG abnormalities may undergo pharmacological stress testing and myocardial perfusion scan. Perioperative cardiac biomarker screening. This is a promising alternative to or in conjunction with other risk stratification methods to predict post-op CVS, morbidity and mortality. There is likely a significant amount of undiagnosed or asymptomatic perioperative MI contributing to 30-day mortality. Biomarker screening is less expensive and resource-intensive than cardiac imaging. It provides promising predictive value for both cardiac and non-cardiac morbidity and mortality. However, more evidence is required prior to widespread implementation. Cardiac biomarker screening includes pre-op natriuretic peptides such as BNP and anti-proBNP, and early post-op troponins. For those identified with abnormal results at high risk of morbidity and mortality, employ medical risk reduction strategies such as antiplatelets, statins, beta blockers, and oral anticoagulants. Duke Activity Status Index. DASI is a questionnaire which defines an individual's exercise capacity through the use of METs, metabolic equivalent of task, where 1 MET is the resting oxygen consumption of 3.5 ml per kg per minute for a 40-year-old 70 kg male. This provides an estimate of functional capacity. However, it may not be as accurate as objective measurements such as CPET. DASI scores were the only assessment of functional capacity to be associated with the primary outcome measure of death or MI within 30 days in a large prospective cohort study by Vijay Sundra DN et al. In 2018. Patients who cannot sustain 4 METs of physical activity frequently have adverse outcomes following high-risk surgery. For 1 to 4 METs, activities includes eating, dressing, dishwashing, and walking around the house. For 5 to 10 METs, activities includes climbing a flight of stairs, walking on level ground at 6 km per hour or more, running briefly, and playing golf. Activities of more than 10 METs include strenuous sports such as swimming, single tennis, and football. DASI has a maximum score of 58.2. The formula to calculate VO2 peak and METs from the questionnaire is included here. CPET. This is a non-invasive objective assessment of exercise capacity. It is a dynamic integrated evaluation of the cardiorespiratory system which reflects the physiological reserve of an individual. It is helpful in predicting post-op outcomes. It is based on the premise that major surgery increases baseline oxygen consumption, and there is a correlation between reduced capacity for oxygen delivery and post-op organ dysfunction. Consensus clinical guidelines on indications, organization, conduct, and physiological interpretation of CPET exist. Indications for CPET includes prognostication of surgical outcome, to inform shared decision-making, to identify patients suitable for prehabilitation, to guide and monitor effects of pre-optimization, to monitor effects of neoadjuvant chemotherapy, to guide intra-op NS management, to guide levels of post-op care, and to identify pathology and causes of exercise intolerance. Preparation and consent. Patients should receive information on the rationale for CPET, its risks and benefits. Full medical history with detail on cardiorespiratory comorbidity and medications is required, along with pre-test hemoglobin. Known risk of adverse events associated with CPET includes incidence of complications requiring hospitalization, 2 in 1,000, incidence of major cardiac event, 1.2 per 10,000, incidence of mortality, 2 to 5 per 100,000. This is a tool for assessing risk associated with performing CPET in various clinical scenarios, referenced from the ARTP statement on CPET 2021. Consider alternatives to CPET if it is not essential for case management. Risk outweighing benefits, such as in acute unstable cardiac status, dissecting or leaking AAA, untreated pulmonary embolism, pulmonary hypertension, and severe aortic stenosis, especially in the failure of risk mitigation. CPET equipment and exercise protocol. Basic CPET requirements includes full resuscitation facilities, a cycle ergometer, a metabolic cart, equipment for serial monitoring of arterial oxygen saturation, NIBP and ECG. 2 staff members are advisable. Metabolic cart consists of calibrated gas analyzer, computer, and screens which display 12-lead ECG, ST segment analysis, graphical displays of physiological changes occurring during exercise. Pressure differential pneumotachograph is attached to the patient's mouthpiece, which measures gas flows and volumes. Incremental ramp protocol is used up until the limit of exercise tolerance is reached. A ramp slope watts per minute is selected using patient gender, age, height, and weight. This can be adjusted according to comorbidity and functional status to achieve testing duration of 8 to 12 minutes. Work rate increment equals peak VO2 minus VO2 unloaded divided by 100. 4 stages to an exercise test includes rest 3 minutes, unloaded cycling 3 minutes, ramp exercise 8 to 12 minutes, and recovery 5 minutes. 3 main variables of CPET are reported in relation to surgical outcome. Impairments of these indices are associated with an increased risk of post-op morbidity and mortality following major non-cardiac surgery. This includes VO2 peak, anaerobic threshold, and ventilatory equivalence for CO2. VO2 peak in mL per kg per minute is the highest oxygen uptake achieved on a rapid incremental test at an exercise. It differs from VO2 max in that it represents the patient's best effort rather than a physiological endpoint. Measured values are compared to predicted values to determine abnormality. If more than 80% predicted, this is not abnormal. 71 to 80% predicted, mildly reduced VO2 peak. 51 to 70% predicted, moderately reduced VO2 peak. Less than 50%, this is severely reduced VO2 peak. Anaerobic threshold in mL per kg per minute is the oxygen uptake occurring at the point when oxygen requirements of exercising muscle exceeds supply and energy provision begins to be met by anaerobic metabolic pathways. Low AT has predictive value of morbidity and mortality in many surgical cohorts, with a value of less than 11 mL per kg per minute, widely used to delineate higher risk patients. AT can be determined by V-slope method, VO2 and VCO2 against work rate, and VE against work rate. This value should be interpreted in the context of other variables and the broader clinical picture rather than used as an absolute threshold for decision making. VE to VCO2 ratio represents ventilatory efficiency at any point of time. High value suggests hyperventilation and/or increased physiological dead space. Values of more than 34 at AT have been associated with adverse perioperative outcomes. Caution should be applied to absolute values indexed to body weight for VO2 peak and AT, as they overestimate risk for patients with high BMI and underestimate risk for patients with low BMI. Interpreting CPET reports. A CPET report consists of an objective assessment of exercise capacity and subjective review of the implications of this exercise capacity for the suggested intervention. The CPET report should be viewed alongside other risk assessment tools to inform shared decision-making process. Key elements of CPET interpretation includes determining the reason for CPET, review the patient's medical history and lab results, note the test quality, patient effort, and reason for termination, present data in tabular and graphical forms, report exercise capacity using AT and VO2 peak, report other indices related to risk such as VE to VCO2 ratio, evaluate the primary cause of exercise limitation, comment on perioperative risk implications, and further investigations advised. Premature test termination criteria common reasons for patients stopping a CPET, and criteria for determining if patient effort is maximal during CPET is included here for completion. Sources of error in CPET, which includes patient, test operator, and equipment errors, are included here for completion, which are referenced from the ARTP statement on CPET in 2021 by Pritchard A. et al. Clinical risk assessment tools in anesthesia. General scoring systems. This includes the ASA Physical Status Classification System, latest update 2020. ASA 1 indicates normal healthy patient, ASA 2 a patient with mild systemic disease, ASA 3 patient with severe systemic disease, ASA 4 patient with severe systemic disease that is a constant threat to life, ASA 5 moribund patient who is not expected to survive without the operation, ASA 6 declared brain dead patient whose organs are being removed for donor purposes. Adult examples, pediatric examples, and obstetric examples are included here. Addition of E denotes emergency surgery. Next is the Physiological and Operative Severity Score for enumeration of mortality and morbidity, POSSUM. This estimates morbidity and mortality for general surgery patients. It is for patients undergoing emergency and elective general surgery. Use values at time of surgery, not admission. Should not be used for trauma patients. Physiological variables includes age, cardiac signs, respiratory history or chest X-ray findings, systolic BP, heart rate, GCS, HP, total white count, urea, sodium, potassium, and ECG. Operative variables includes operative severity, multiple procedures, total blood loss, peritoneal soiling, presence of malignancy and urgency of surgery. Formula for morbidity and mortality calculation is included here. Surgical Outcome Risk Tool, SORT. This is a pre-op risk prediction tool which estimates the risk of death within 30 days of inpatient surgery. Variables for the model to be included includes type of surgery, severity of surgery, ASA score, urgency of surgery, whether thoracic, GI, or vascular surgery, presence of cancer, age, and clinical risk assessment. Next is the American College of Surgeons Surgical Risk Calculator. ACS NSQIP Surgical Risk Calculator estimates the chance of an unfavorable outcome. The data input form showing required variables are included here. The Charlson Age Comorbidity Index CACI predicts 10-year survival in patients with multiple comorbidities. The formula for 10-year survival calculation is included here. Scores for cardiac risk. Revised Cardiac Risk Index. This estimates risk of cardiac complications after non-cardiac surgery. Original study was published by Goldman et al. In 1977. Recent systematic review by Ford et al. In 2010, including 792,000 patients from 24 studies, found that RCRI showed risk of major CVS events, including death, being 2 to 10 times higher than previously reported. Two drivers for this effect includes routine use of high-sensitivity cardiac troponin over CK and inclusion of validation studies that enrolled patients undergoing emergent surgery. RCRI did not perform well in predicting death in all corners due to high heterogeneity between studies and CVS events in patients undergoing vascular surgery. Data from 4 prospective studies and 1 retrospective study were combined to calculate pooled event rates for each of the RCRI scores in a study by Gupta 2017. Formula to calculate RCRI includes addition of the selected points, elevated risk surgery, which includes intraperitoneal, intrathoracic, or suprainguinal vascular surgery, history of ischemic heart disease, history of congestive heart failure, history of cerebrovascular disease, pre-op treatment with insulin, and pre-op creatinine of more than 176.8 micromole per liter, with 1 point assigned for each risk factor. RCRI score of 0, risk of major cardiac event 3.9%, score of 1, risk of major cardiac event 6%, score of 2, risk of major cardiac event 10.1%, RCRI score of 3 or more, risk of major cardiac event 15%. A large-scale external validation using 34,000 patients, an update of renal variable is underway by Pavel et al. Using data from the VISION study by Population Health Research Institute at McMaster University. Scores for respiratory comorbidity. This includes the ARISCAT score, assess respiratory risk in surgical patients in Catalonia. This is the only score that has been externally validated. It predicts the risk of pulmonary complications after surgery, including respiratory failure, for patients undergoing surgery under general, neuraxial, or regional anesthesia. Variables includes age, pre-op SpO2, respiratory infection in the last month, pre-op anemia, surgical incision, duration of surgery, and emergency procedure. ARISCAT score of less than 26, risk of in-hospital post-op pulmonary complication 1.6%. ARISCAT score 26 to 44, risk of in-hospital post-op pulmonary complication 13.3%. ARISCAT score of 45 or more, risk of in-hospital post-op pulmonary complication 42.1%. The Gupta post-op pneumonia risk score predicts the risk of pneumonia after surgery. The formula for post-op pneumonia risk calculation is included here. Variables include age, COPD, functional status, ASA class, sepsis, smoking, and type of procedure. Gupta post-op respiratory failure risk calculation predicts the risk of mechanical ventilation for longer than 48 hours post-op or re-intubation within 30 days. Formula for calculating post-op respiratory failure risk is included here. Variables includes functional status, ASA class, sepsis, emergency case, and type of procedure. Arozullah post-op pneumonia risk index predicts post-op pneumonia after major non-cardiac surgery, and Arozullah respiratory failure risk index predicts post-op risk of respiratory failure in elderly males based on available clinical data and type of surgery. Scores for specific operations or operation types includes Nottingham hip fracture score, POSSUM for vascular surgery, British aneurysm repair score, and National Emergency Laparotomy Audit Risk Prediction Tool. J. Stones published an article under BJA Education in 2019 comparing clinical risk assessment tools in anesthesia. This table shows a comparison of ASA, Revised Cardiac Risk Index, and ARISCAT scores. For ASA, outcome is population-based mortality. Advantage, simple to use and correlates with outcome in a number of settings. Disadvantages, scoring is subjective and does not consider surgery plan. For Lee's Revised Cardiac Risk Index, outcome is post-op cardiac complications for non-cardiac surgery. Advantages include simplicity, non-invasiveness, and identifies those at risk before operation. Disadvantages, it is developed 20 years ago in a single center from elective patients, thus uncertain generalizability. ARISCAT score, outcome is post-op pulmonary complications. Advantages, identifies those at increased risk and contains modifiable features. Disadvantages, no widespread agreement in how post-op pulmonary complications are defined. This table shows a comparison of V-POSSUM, NELA, SORT, and ACS NSQIP. Predicted outcome in V-POSSUM is 30-day mortality. Advantage, it is comprehensive and considers patient and surgical factors. Disadvantage, it requires estimation of intra-op findings. It contains subjective elements and overestimates mortality in high-risk groups. NELA predicts 30-day mortality. Advantages includes accurate and specific for emergency laparotomy patients. Disadvantage, time-consuming, requires estimate of intra-op findings and no morbidity component. Predicted outcome for SORT is 30-day mortality. Advantages includes simplicity, readily available pre-op data. It is generated from emergency and elective patients across a wide range of surgical specialties. Disadvantage, no morbidity component. ACS NSQIP predicts 30-day mortality and morbidity, risk to return to theatre, readmission, and discharge to post-acute care facility. Advantages includes comprehensive patient and procedure-specific morbidity and mortality risk. Disadvantages: time-consuming, expensive, and data is from private hospitals in USA, hence uncertain generalizability. Thank you.